to be with all of you. I've been asked to look at the standards that have been put forth by the World Confederation for Physical Therapy as it relates to not only practice but education, and also the entire conceptual framework of direct access. I think the basis started when we looked at the practice here in Poland and realized that direct access was still not inherent by law. So therefore, it was inherent that we look at all of the standards that have been set from the international community. Is there a clicker? Oh, I got it. So we'll go over very briefly the standards of practice. And I've tried to write on my slide all of my words since I know I'm speaking with a multilingual group. So if there are any questions, please stop me. I'm happy to be interrupted anywhere along the way. But certainly our standards of practice are no different for physiotherapy than they are for medicine, than they are for nursing, for any other health profession. So they do give our statement of conditions and performances that are essential for the provision of very high quality professional services to the society and form the foundation for our assessment of physical therapist practice. It's our commitment to promote optimal health and functioning in the individuals that we serve. Why do we have these standards? Obviously, we recognize the absolute importance of developing and documenting agreed upon standards. And they're necessary to demonstrate to the public that we serve that physical therapists are concerned with the quality of services and are willing to implement self-regulatory programs to maintain that quality. We do support entry-level physical therapist professional education, and I'll come to that in a little bit more. We facilitate continuing professional development. The standards are necessary to guide our practitioners in the conduct and evaluation of their practices, and in this case, to provide governments and regulatory bodies and other professional groups with the background information about professional practice. And last but not least is effectively communicate with members of the profession, employers, and other health professions, governments, and the public. So our standards of practice represent the profession's commitment to society promoting optimal health and function, and it provides the basis for physical therapist practice in all settings, including but not limited to clinics and hospitals and schools and commercial enterprises. Now, our standards span many different areas, as the standards of every profession do. We look at the standards of practice related to administration, and what's really key from the WCPT perspective is that the physical therapist is totally responsible for the direction of the physical therapy service, regardless of the type of environment in which those services are provided. So we ensure that compliance with statutory requirements are there, that the services are provided in accordance with policies and procedures, that we train any support personnel, that we train on safety issues, and we do evaluate the whole practice. Our standards also include the aspects of collaboration, and we know in this day and age that collaboration is essential with all appropriate health professionals. We know that the qualifications and the roles of other professionals involved, and we know how to interact with those, again, on an equitable basis. And we also look at the importance of the appropriate team approach when assuring relevant communication. Our standards also relate to communication between the director, manager, staff, and organization of a facility, but also making sure that available policies and procedures are on site. Fiscal management is another aspect of our WCPT standards of practice, where we look at the director or manager of the physical therapist services in consultation with staff and administrative. We also plan and then allocate resources and also assure that there's a fiscal management plan for optimal use of resources. The next aspect of our standards of practice relate to the establishment of mission, goals, and purposes, which every organization must do. But in our case, those statements have to reflect the needs and interests of our patients and clients that we serve and the physical therapy personnel that are also within the practice environment. Our organizational plan is another aspect of our standards of practice, and that describes relationships amongst the components of our services and ensures that service is directed by the physical therapist. In addition, we look at the whole arena of the physical setting as it pertains to standards of practice. And as every environment must have, it must be safe, it must be accessible, it has to also have sufficient equipment that is also safe. We must assure that there's adequate space and proper environments to meet the professional, educational, and administrative needs of the service, that it meets all applicable legal requirements for health and safety, and that the treatment areas offer privacy, security, and comfort. Obviously, we must look at the whole aspect of equipment in terms of meeting the legal requirements for health and safety, and we must assure that our equipment is inspected and maintained routinely. Our standards of practice also relate to policies and procedures within the practice, and therefore we're looking, as every organization must do, the written policies and procedures that do reflect our mission, our purposes and goals, and are consistent with WCPT standards. And we must assure that these are reviewed regularly and revised as necessary. Obviously, the referral is also an important aspect of the standards of practice for WCPT, and here we look at a referral system that is in place to ensure that the patients and clients can access a physical therapist either by direct access or from an appropriate referral source. So we look for either to be appropriate. Then let's take a quick look at our education standards, and here forms the basis of much of the information that you had presented just prior to my presentation. When we look at our standards of education from WCPT, we look at physical therapy as an established and regulated profession with specific professional aspects of clinical practice and education. Is clearly a single profession and is the first professional qualification obtained in any country, and we must assure that that, again, represents the completion of a curriculum that qualifies the physical therapist to use the professional title and, most importantly, to practice as an independent professional. In addition, our standards state that the physical therapist professional entry-level education programs are to be based on university and university-level studies, minimum of 4 years. I know you're 5 years here in Poland, we're 7 in the US. But it's independently invalidated and accredited as being at a standard that accords graduates full statutory and professional regulation. The standards of education further go on to state that any program is expected to deliver a curriculum that will enable physical therapists to attain all requisite knowledge, skills, and attributes. The standards further go on to say that entry-level educational programs must integrate theory, evidence, and practice along with a continuum of learning. And we certainly heard enough about evidence-based practice and its importance in all of our practice areas in this day and age. The goal of physical therapy education is continuing development of physical therapists who are entitled, consistent with their education, to practice the profession without limitation in accordance with the definition of physical therapist practice in individual countries. Physical therapists should be equipped for evidence-based practice, and the curricula for physical therapy education should be relevant to the health and societal needs of the particular nation. The curriculum should equip physical therapists to practice in a variety of settings, not limited to, but including institutional, industrial, occupational, primary healthcare that encompasses rural communities, and then consideration must also be given to preparing physical therapists to practice in environments that reflect the delivery models that operate in different countries. So our first professional qualification should represent the completion of a curriculum that qualifies our physical therapists for practice again as an autonomous independent practitioner. So now a few words about direct access or autonomy. And this doesn't mean that we operate in a vacuum and that we don't interact with professionals as we should. In this day and age, as I mentioned earlier on, it's essential for all of us to respect each other's profession, but also to make sure that the interaction occurs for the best needs of the patients and clients we serve. So in looking at autonomy, and I'm going to try to go through again the WCPT standards on autonomy and direct access, and then to give you some of the early data and to bring you through where some of the more recent data has pushed us. The WCPT advocates that direct access to physical therapy and patient-client self-referral will allow service users to meet their physical therapy goals. The entry-level education prepares physical therapists to be first-contact autonomous practitioners. So we are able to examine or assess, evaluate, diagnose, prognose, intervene, treat, as the terminology might use, and determine the outcomes and discharge needs of our patients and clients without the referral from another health professional, whether it's medical practitioner or nurse practitioner or physician's assistant or however it might be in any country. Our service developments and delivery models allow patients and clients improved access to physical therapy services through the ability to have themselves directly refer to a PT. Looking at, again, the history of direct access, the requirement for patient-client ability to be referred by a medical or dental practitioner began to be questioned back in the 1970s in Australia and particularly in the United Kingdom. Physical therapists asked themselves there if there was really an ethical, justifiable reason for this requirement. And supporting the move away from the model of dependency was the profession's growing knowledge base and also our major emerging research culture. In addition, professional bodies were developing codes of ethics and professional insurance and other means of accountability to ensure public safety when self-referring. And concomitantly, there were changes in physical therapist practice that, again, occurring in many countries. For example, in the US, we had a very successful model for direct access to physical therapy services that was developed by the military to optimize access to injured personnel. Further on, direct access and autonomy began to become a focus of WCPT policies as early on as 1995. And the policy statement clearly stated that patients and clients should have direct access to physical therapist services. Direct access or self-referral, again, refer to when patients are able to refer themselves to a physical therapist without having to see anyone else first or without being able to be told to refer themselves by another health professional. And this could relate to anything from telephone to face-to-face services, as well as those that are delivered by any new media, such as over the internet in this day and age. Direct access, as far as WCPT was concerned, also occurs when the patient-client self-refers to the physical therapist as an outpatient or in a primary care setting. And it's also relevant, obviously, to inpatient services, and we've seen an exponential amount of physical therapist intervention in the emergency departments nowadays. We're finding out that many of the emergency departments are referring the musculoskeletal problems immediate to a physical therapist in the ERs, and again, they're being triaged and again appropriately referred after that. In many countries around the world, physical therapists do have direct access, and I would make a plea that here in Poland you begin to think about legalizing direct access to physical therapy as soon as possible. Direct access to physical therapy services is supported by national, provincial, regional, and state legislative frameworks and by the standards of our professional practice of physical therapists. So we advocate for the right of those seeking physical therapy services to self-refer. We believe that this right promotes the autonomy of users of PT services and enables fair and equitable access. And we advocate for health insurance reimbursement models that do not require a referral of a medical practitioner before a patient or client may seek the services of a physical therapist. And as I mentioned there's a growing body of research evidence that supports the clinical and cost effectiveness of such services and their accessibility and also acceptability among service users. One of the most effective tools for cost control and increased access is, again, the direct access to physical therapy services, and yet is still overlooked and underutilized in many areas. So why direct access? First of all, demographic changes are resulting in the requirement of different use of health services. Consumers will be increasingly informed about the choices available to them and have higher expectations of health services. And given the financial constraints, services and interventions are increasingly needing to demonstrate both clinical and cost effectiveness. Again, our health policies throughout the world are stating that the need for patients and clients to be able to self-refer directly to the health professional of choice. And our health services delivery is moving increasingly more into the primary care settings, and the removal of the barriers to direct access to physical therapy provide a number of key advantages for the patients and clients, including more choice. So one has got to remember that entry into the profession and practice are stringently regulated. Physical therapists are highly trained professionals and have a proven track record of effectively treating millions of patients around the world. We're well qualified both through formal education and clinical training to, again, provide the appropriate examination of our patients and clients and to assess their needs and, if appropriate, safely and effectively treat those patients and clients. And we're well qualified to recognize when patients demonstrate conditions, signs, and symptoms that should be evaluated by other health professionals before physical therapy is instituted. And we also recognize it is appropriate to refer patients to other health professionals for consultation. So what have been the big opponents to direct access? Well, they argue in countries where the profession hasn't obtained direct access that there have been tensions between the medical profession, who said that physical therapists do not have the diagnostic skills to act as primary contact professionals. I think we could argue this point for a great deal, and I'd be happy to take this one on head on at any time. Others have argued that using particularly the scare tactics, which I personally hate, that physical therapists are going to overlook the serious medical conditions, that we're going to miss the cancer of the spine. I would argue personally that we probably have more of an opportunity to, again, pick up that there might be some difficulties, because if we see a patient who's been referred to us with a low back disorder, we start and institute, first of all, our examination of that individual. We ask them all the pertinent questions about where their pain parameters are and when the pain exists. And after 3 or 4 sessions, if there's no response and a change in any symptomatology, that patient is going to be referred immediately back for enhanced and, again, other kinds of evaluation procedures. So I would be willing to bet, again, that there's very, very little chance of this ever occurring. So when we look at, again, the areas of concern that have been put out there, it has been first that the users of physical therapy services are going to be placed at risk if they don't have a physician referral. And secondly, in that introducing direct access to physical therapy services is going to result in significantly more users of PT services and their increased costs. Well, what does the research say? First of all, about those 2 primary concerns, it says no evidence to support either concern. Not all patients and clients will self-refer, even if it's available. For example, in Australia, where self-referral has been possible for over 30 years, approximately 65% of the patients use it. Research data has shown that patients and clients support direct access and self-referral when they're informed of its availability, and those who self-refer report similar levels of satisfaction with their interventions to those referred by a physician. And the availability of direct access and patient-client self-referral may result in patients and clients taking more responsibility for the management of their health problems. So what do the data actually show? And I'm going to try and start with some of the earliest studies. I'm not going to go through all of them, but I've tried to highlight a few of the key studies that are out there. Mitchell did one of the very early studies back in 1994 in the United States, when she assessed whether direct access to PT services provided a licensed physical therapist, whether it's cost effective, and she found very interesting results. The total paid claims for physician referral episodes to PT was 123%, or 2.2 times higher than the paid claims for physical therapist direct access episodes. The total claims that were paid were averaging $2,000 or more for physician referral episodes as compared to $1,000 for physical therapist direct access episodes. Physician referral episodes were 65% longer in duration than those for physical therapist direct access episodes. And finally, she found that physician self-referral episodes generated 67% more physical therapy claims and 60% more office visits than physical therapist direct access practice. So way back in 1994, we knew that we could begin to make some major cost savings within the service delivery system. In 1999 and up in 2000, Decker and White and also Daly in the United States again looked at the clinical studies that were available that demonstrated that physical therapy services actually decreased a patient's risk by decreasing the need for higher risk, more invasive treatments. Justin Moore did a study in the United States in 2005 where he looked at a retrospective analysis of 472,000 patient visits at 25 military facilities. And he found that 45% of the visits were determined to be patients that were to be managed through direct access to physical therapists and without physician referral. And there were no adverse events that were reported from the physical therapy diagnosis or management. Holdsworth did a study in 2006 in the United Kingdom that showed that those that self-refer have knowledge of physiotherapy, and self-referred patients report shorter duration of symptoms. Ely also did a study in 2006 in the United States that showed the risk to the patient from physical therapy diagnosis or intervention is extraordinarily low and with substantial benefits. In addition, it showed that while higher risk, there were more invasive interventions have a role in select situations than general public would have if the option to seek conservative care through direct access to physical therapy services. Holdsworth did another study in the United Kingdom in 2007 and showed that self-referral to physiotherapy was associated with lower costs as compared to GP referral. Limerick did a study in 2008 in the Netherlands that showed that 28% of patients self-refer in the Netherlands. Patients tended to be younger, higher educated, and their symptoms tended to be under a month in duration with past experience with PT. Aiken did a very amazing study in Canada in 2008, and she found that the diagnostic accuracy of physical therapists had been directly compared to orthopedic surgeons in prospective clinical trials, and that physical therapists were found to be as diagnostically accurate as the surgeons. And I think we saw this already this morning. 90% were in accordance in diagnosis of knee and shoulder problems. There was 75% accuracy when compared to definitive diagnostic methods, and 87% agreement in treatment recommendations. Pendergrass did a study in 2011 in the US and examined non-Medicare claims patients who visited physical therapists directly for outpatient services, and found that these patients had fewer visits and lower overall costs on the average than those who were referred by a physician after adjusting for age, gender, diagnosis, illness severity, and also calendar year. And Pendergast also found that the overall related health service delivery use or care related to the problem for which the physical therapy was received was lower in the self-referred group after adjustment. Harwood did a study in 2016 in the US and analyzed private insurance data and found that seeing a physical therapist for the first low back pain episode produced a host of positive results. And Ken found that there were lower costs, including lower out-of-pocket costs. There was reduced probability of an emergency department visit, and there were also lower rates of opioid prescription. As we all know, I don't know how it is here in Poland, but the opioid addiction in the US is just beyond belief. And I think all of this stems from it's very easy to pop that pill rather than, again, looking for alternative types of interventions. Denninger did a study in 2017 in the US and analyzed claims and outcome data for 447 patients receiving PT for back or neck pain, either by direct access or medical referral. And these data showed that patients in both groups received the same guideline-based care using the same outcome measures. The improvement in pain and disability was similar, but the direct access patients with neck and back pain incurred $1,500 lower average costs than those who chose referral from a physician. And again, there were no adverse events. The 276 patients who chose direct access had significantly fewer physical therapy sessions with a mean of 0.9 and fewer days in care with a mean of 10.5. In a study that was in Denninger's further workup, they found that when patients chose to see a physical therapist first, there were no identified incidents of misdiagnoses or delays in care as a result of the physical therapist's clinical decision-making, and it suggested that physical therapists utilizing a standard evidence-based screening questionnaire could adequately determine appropriateness of PT interventions. In addition, they found that, and this was particularly important finding, that since patient safety is often noted as a counter-argument to the direct access to physical therapy services, these data certainly mitigated that concern. And then McDonough finally did a study this past year in the US where he analyzed insurance claim records for nearly 60,000 adults across the US with new onset low back pain. And what the study revealed that the average 30-day costs were the lowest for patients in states with direct access to physical therapists with no restriction to access and who actually saw a PT first for their low back pain. So there are also some data to support, again, the relationship of practice and education. And a recent survey suggests that graduates of entry-level programs in most WCPT member organizations certainly have the required competencies to accept patient-client self-referral upon graduation. The WCPT guidelines for PT entry-level education recommends that graduates are prepared as first contact autonomous practitioners. And direct access patient self-referral brings with it a set of responsibilities, and it is best provided in the context of approved appropriate regulation of the profession to ensure that those standards of education and ongoing practice, again, protect the public. So in summary, direct access and self-referral to physical therapy is clinically and cost-effective and results in satisfied patient clients. Direct access self-referral puts patient clients in control of their health choices. Patients and clients who refer themselves to physical therapy are more proactive, more autonomous in making health decisions, take less time off work, return to work sooner, are more likely to complete a course of treatment, are more interested in self-management, are more satisfied with their services. Direct access and self-referral saves money through reducing costs to seeing other health professionals, less prescribing, less investigations, less secondary care, reducing costs to society through time off of work, and less administrative costs. So there's no doubt that direct access and self-referral does not lead to increased demands for services if they are adequately resourced. And as importantly, direct access and self-referral is not just appropriate for musculoskeletal services, but across the areas of practice. So I think hopefully I've given you the basis of WCPT's positions as it relates to our standards of practice and our standards of education, and again, our whole arena of the desire of physical therapists to be self-autonomous practitioners in every country around the world. So thank you very much for having me here today. It's been my pleasure to be with you.